Okay. Well, let's go ahead and get started. I know we have a lot to talk about and go over this afternoon. So thank you so much, everyone, for joining. I'm Allison Fiscalini. I'm the director of the Athena Breast Health Network and the Wisdom Study. And we're excited to present to you today the Wisdom Study, bringing breast screening and prevention into the 21st century. So just to start off on the next slide, a few reminders and the format for today's session. Microphones are muted and the meeting is being recorded. We would love to hear your questions. So if you put your questions in the Q&A function at the bottom of the screen, we can then either answer those live or present them during our panel discussions throughout the session. We will also email you with a short post-meeting survey. We'd love your feedback. We'll keep doing these webinars, but really would love to hear what you enjoy, what you would suggest for improving, and other topics you'd love to hear about. So thank you so much for joining us today. So the agenda for today will go over introductions, who our fabulous speakers are today, learning some lessons learned from decades of screening. What have we learned? Where can we go from here? Who is getting screened? What are the barriers? What's breast cancer incidence? And what are the death rates by race and ethnicity? Why does this all matter? And how can we try and improve it? How can we make a difference? How can we make it better? And then talking through the Wisdom Study, how it came to be, how to participate, and importantly, how you can get involved. So I would first like to introduce Dr. Laura Esserman. She is the director of the Breast Care Center at UCSF. She also is the lead and founder of several large initiatives, including the University of California-wide Athena Breast Health Network, the I-SPY trials, the Wisdom Study, and many, many other great projects and research going on. She's a breast surgeon as well. But in her spare time, she is a singer, songwriter, theater performer, mentor, family person, my boss, and professor.
That's why you have to say all those nice things, Elle.
And next up, we are so happy to have Ricki Fairley join us today. She is a breast cancer thriver and advocate. She's the co-founder of Touch, the Black Breast Cancer Alliance, and founder and co-host of The Doctor Is In, which is a weekly live web series on blackdoctor.org. And she is an award-winning and seasoned marketing veteran, mother and grandmother who lives in Virginia. So welcome, Ricki. And then third up, we have Nola Hilton. She is a professor in the Department of Radiology and Biomedical Imaging, here at the University of California, San Francisco. She is the director of the Breast Imaging Research Group at UCSF, and she's been integrally involved, in the development of magnetic resonance imaging, MRI, and the detection, diagnosis, and staging of breast cancer. So we'll hear a little bit more about her work in MRI and what role it plays in breast cancer screening in this webinar.
And Nola started the I-SPY trial program with me. So there you go.
All right, so thanks everyone for joining, and we'll let Dr. Esserman take it from here.
And we should probably introduce Margarita Watkins also, who's here. Nola, you want to introduce Margarita? Can you hear? Yeah. You're on mute.
Yes, can you hear me?
Yep.
Yes, Margarita is the heart and soul of our breast imaging program. She is extraordinary. She's the interface with our patients, and so knows so firsthand about all the issues with having women come in for screening and introducing them to breast MR usually for the first time. Knows her way all around both the scientific community and the clinical community and the university community. So she is here to add her insights to the panel.
And has been working with Nola and I on these initiatives for, gosh, over 20 years, that's for sure. But we'll stop at that.
I got one to say too.
Okay, so I thought today what we wanted to do is just talk a little bit about breast cancer and what we've learned about breast cancer and how that applies to screening, to maybe try and give some insights as to why we think it's worth trying a slightly different approach or a different approach to screening and prevention. And part of the reason is that we now know that breast cancer isn't one disease. You know, when we started screening, that's what we thought. We thought it was one disease. And we've changed over time, right? Treatments change and we don't treat everybody the same. We, you know, are very much more tailored in our treatments. We have diagnostic tests that we do to really understand the genetic composition, the genes that make up our tumors. And these are used to decide who needs hormone therapy, who needs chemotherapy, who needs biologically targeted therapies. So since that's changed so much, it does seem like it's time for screening and prevention to become more personalized or tailored as well, to really focus on this fact that there are lots of different cancers that compose breast cancer. And, you know, when we first started screening right around here, 1983, what we noticed is that there was an increase in the risk of cancers overall. Now, interestingly, when we first started, if you look right here at these localized cancers, and we said, well, look what happened. We had, these are the early treatments, the early stage 1 cancers. And so when you're thinking about node negative cancers as a fraction of all cancers detected, you know, from 1982 to 1998, this looks like a big success, a big increase in the fraction of cancers that are detected early. That is the sine qua non of what you want to see in a screening program. But what we didn't really understand at the beginning was these cancers went up, but these regional cancers or node positive cancers only went down a little bit and not as much, and that the overall rate went up. And so what we see over here is that a big part of this fraction is because there was an increase in the total number of these early stage cancers. That was a surprise. We weren't expecting that, but we've now seen this in screening a number of other diseases. That's true. When you screen a population, you will also find the reservoir of slow growing cancers, not all of which are destined to be killer cancers. And so from the old way of thinking about it, when you went from a normal cell to atypia to in situ disease to stage 1, 2, 3, and cancer, if this is the path that all of these cancers take, for sure, early detection will make a big difference. But it hasn't made as much of a difference as we thought it was going to. So that has made us realize that there are some cancers that you can find that are very slow growing. And they may not come to attention over your lifetime. And the way this works is this is years. Each of these are screening intervals. And this is the rates of growth of these tumors. And this is when something might be detectable microscopically, all localized, and when it would spread. And the other thing it made us realize is that there are fast growing cancers. These are cancers. When people show up with these big cancers, we used to tell women, shame on you, you didn't go in first, it's your fault. That actually turns out not to be correct. That some of these cancers are just fast growing. And screening the way we do it today may not be the best way unless we can figure out who's got the who's at risk for these fast growing cancers, and maybe screen people more frequently, or better yet, figure out how to prevent them. So it's not as good as it should be here. We'll talk a little bit more about that. The moderately growing cancers, that's where screening is going to shine, where it's going to have its biggest benefit. And we have to be aware of this problem so we don't accidentally overtreat women who are found with these kinds of cancers. This is what when you hear people talk about overdiagnosis, that's what they're talking about. So we've got to have screening reflect our new understanding of breast cancer biology. And, you know, I think part of the problem is that our screening guidelines came from data that was generated in the 80s and 90s, you know, 70s, 80s, and 90s, when in fact we only thought that breast cancer was one disease. We didn't even know what an estrogen receptor is. And on the basis of that data, many countries around the world, looking at the same data, you know, the United States is the only one that screens every year, starting at 40. But even within the United States, there's lots of controversy. The United States Preventive Services Task Force guidelines recommends shared decision-making for, you know, to sit down and talk to your doctor about whether you need to start early, and otherwise screening every other year starting at 50. Whereas the American College of Radiology and the Society for Breast Imaging says you start at 40 and you go until your life expectancy is less than 5 to 10 years. The American Cancer Society recently changed their guidelines to start at 45 and screen annually, and every other year after 55. NCCN guidelines follow more of the American College of Radiology guidelines and so on and so forth. So there's many different ones. But the interesting thing is that all of these guidelines kind of treat everybody the same, except they tailor by age. And the real question is that really the right way to do things? Now, when you look at the breast centers, there's about over 600 breast centers in the country, and the vast majority provide advice about when to screen. And almost all of them provide recommendations that are different from the US Preventive Task Force guidelines and follow the American College of Radiology guidance, and they don't follow the ACS guidance either. And only 12% of centers recommend shared decision-making for women in their 40s, like the US Preventive Task Force guidance does. But that really puts the burden on both the internal medicine folks and patients, really, because we don't really have good information about risk assessment, and the differences in screening are very confusing. And there's just so much out there that's confusing that it makes it really challenging for people. And you may ask, why even have a concern? Why not just do more? Why not just screen everybody starting at 40? Why can't we just, why are we even arguing about this? Is it really that people are trying to save money? Actually, it's not. And the reason why almost all the internists support the US Preventive Task Force guidelines is because the way they look at the data, there's similar benefits to annual screening, but with fewer harms, that there's more false positives. I mean, the chance that you're going to be called in because of an abnormality on your mammogram is, almost, 50% higher if you screen every year. And false positive mammography results really cause a lot of anxiety. And in fact, each time someone's called back, the chance that they're going to go back for their screening exams is less. So we sometimes shoot ourselves in the foot. And many other, screening guidances, such as cervical cancer screening, has now, gone down to every 3 years. Colon cancer screening, you screen at 5 or 10 years, depending on whether you have polyps. So we've been able to make these kinds of changes in the screening of other diseases because of these very similar issues. But it's so emotionally charged in breast cancer that it gets everyone so upset that we can't even have a rational conversation about it. And the chance that you're going to get a false positive biopsy, actually have to go through a biopsy, is, again, a third to half higher if you screen every year. But one of the problems is that the deaths in younger women are not really reduced through annual screening. And that's actually one of the clues. And Dr. Hilton and I, Nola Hilton and I, actually run this trial called the I-SPY trial for women with more aggressive cancers and larger cancers. And actually, most of the women who come in that trial come in because they found the cancers themselves. They come up because they're happen when you're too young for screening, or they come in between because the cancers grow faster. So what that tells us is that there's a lot of room for improvement. And, this issue of overdiagnosis is higher. The more you screen, the more you find, of course. And so that's why there's a controversy. We're not weighing in about right or wrong, because that's not what we're talking about today. We think that there might just be a better way forward to do that. And then if you stop and look at the data, in most of the organized countries, like in the UK or Sweden or the Netherlands, about 80 to 90% of the population gets screening. They recommend, less frequent, but that's what they do. In the United States, we have somewhere between 60 and 70% of the population screened. So the question is, who are the people who are not getting screened? Are they really people who have lower risk, or are we just missing the boat and these are the people who need it more? And there isn't a huge difference among the races, although Hispanic women tend to screen a little bit less frequently. But we still have, and where it's more closer to 55 to 60%. Again, who are we missing? We can do better. And we find that most people are just very confused. And some people just say, well, if they can't figure it out, I'm not going to go in and screen at all. And so I think we're in the situation where some women may be getting screened more than they need to, and some women aren't getting screened at all when they probably should be. So I wanted to just stop there, and Ricky, maybe get some comments from you, and Margarita from you about these issues.
It's really a dilemma, especially in the Black community, because so many people aren't getting screened and not getting screened. You know, I think there's a lot of confusion. There's a lot of confusion. And for young Black women, the data that we're seeing, Doctor, is that Black women get breast cancer at twice the rate under the age of 35 and die at 3 times the rate under the age of 35. So when do you start screening? When do you get the risk assessment? When do you kind of start the conversation? And I think one of the things with the Black communities, we don't talk about disease in our families. You know, I always say we don't know her story until somebody gets sick. And so we don't talk about breast cancer. We don't talk about screening. And then all of a sudden somebody's got breast cancer, it's metastatic. What do you do, right? So the screening conversation has to be elevated in our community. But yet again, based on everything we've talked about just now, when do you do it? How do you do it? How do you know? How do you find out? How do you have access? And all of those things are on the table for our community.
Right. And the way we screen today isn't helping the problem that you've raised.
Right.
We've got to do better.
Right. And just to add on to that, there is a stigma around the mammogram process, how painful it is, the anxiety around it. I think those things are not being addressed as well. Like you said, I work in MRI imaging, and whenever I encounter a patient that has anxiety around having the MRI, we've gone as far as letting a family member that is properly screened for metals sit in the room while the patient is being imaged, just because that brings an added layer of comfort to the person around the anxiety of having the MRI. And even though they can't hear that level and can't talk to them during the exam, just knowing that they're there, I think there aren't enough systems in place around the anxiety of a mammogram to address that part, and just to get the patient through that much, or get the person through the mammogram, which is the first stage of the screening process. I just don't think maybe like Ativan or a person there for comfort, or feeling empowered to tell the tech, can we stop? Can I take a break? This hurts. Like I said, I come from a big family of women, 7 girls on my mom's side and 14 on my dad's side, all women. And just the stigma around the pain of a mammogram and how brutal and traumatizing the experience, that's a story that gets passed on. And I myself, even working in breast imaging and breast health, took forever to get a mammogram, just because my mom came home super bruised from one and cried, and she had really large breasts. And I just think that how it was handled was not sensitive to that regard, and her fear and her anxiety, none of that was like addressed, and it just wasn't enough done to help her through that process. So she felt so traumatized. She didn't go back for regular screening throughout the course of her lifetime. So, and my aunts didn't go because of the way she felt about it and what happened to her. So I think that even when the conversation comes up about screening or mammograms, there are these sort of horror stories that some people have experienced. And there is a disparity in healthcare when it comes to minority women. And when we go to the hospital or to the doctor for certain things, our experiences are not always the same as everyone else. You know, whenever I go to the ER for any reason, it doesn't matter what I'm going there for, I get a drug screen. And so it's just kind of like, what is that for? And I know that it's happening because I work there, so I can see my own medical record. And I'm always curious, like, why is that a part of ruling out, like, why my stomach hurts, or why I have a migraine for the past 2 weeks? Or so I feel like my experience is not the same as the experience I've had with other colleagues or other ethnicities who suffer from migraines as well. They don't encounter those kind of things if their migraine sends them to the ER. The experiences are just not the same. And so there's that's sort of like a stopping point for even wanting to do it. And I think that needs to be addressed, the anxiety around it, and how do we deal with that? How do we comfort a patient? How do we get them in the door and assure them that the experience is going to be okay?
Well, I think that's a great suggestion, Margarita, and I think it's things that we can band together with some of our colleagues who are doing mammography imaging, and we can write a little pearls of wisdom for people who are in the trial to sort of say, how can we what are ways in which we can make mammograms less stressful and less scary? And I think that people don't realize that when there's a lot of compression, if it's really hurting, we're always taught that the more you compress, the better picture you have, which of course is true. But, you can also say, wow, that's too much. I can't tolerate that. You got to back off. And that people should be empowered to say that. But I think also just find ways to make it more comforting. But again, this brings up the point that people don't love getting their mammograms. It's not that fun, so that if you can safely do it less often, that should be welcomed by people and not be seen as something that's being taken away. And if you need it more often and you knew that there was a reason for it, you'd be more motivated, to do it. And, I think that one of the things that we've learned too is that it used to be that white women had a higher chance of getting breast cancer, but I think with screening, that's now about the same. But again, as Ricky was saying, Black women have higher rates of getting cancer when they're young. And it's partly because of the type of cancer that is more frequent in African-American women. It's the so-called hormone negative or triple negative breast cancer. It's just more likely, it's actually more likely in African women, a little bit less frequent in African-American women, and then definitely less frequent in white women. But when that disease comes, it behaves the same way. It's faster growing and more aggressive. And white women tend to have more cancers that are more frequent later in life. And again, as we get better at treating these different kinds of cancers, we hope that the mortality rate differences are going to get lower because we know better how to treat them. That's one of the things that Nola Hilton and I are working on in the I-SPY trial. And, for every ethnicity, breast cancer is important. It's still the most common cancer in women. And for Latina women, it's, the highest, it's the leading cause of cancer death. And as women stop smoking, breast cancer will still be that unless we do a better job at prevention. And so how are we, so this is why we are running the Wisdom Study. We're trying to improve the approach for screening and prevention by integrating risk assessment into the whole idea of screening and then coupling it with prevention. So this is a modern era trial, so challenging the notion that everyone should be screened the same. Topics for another webinar, things that we can do is, there are tools to help identify whether, how aggressive your treatment should be. And we're actually trying to develop tools to be able to identify the people at risk for these more aggressive cancers, which then we could apply earlier at an earlier age. If we show that the approach in the Wisdom Study is right, this is something we could start for women who are younger to do a risk assessment and know who should be screened early. Most people aren't going to be in that high risk group, but if we could really sort that out, it would be a huge advance for actually women of all backgrounds, but especially those who are a little bit more at risk for these aggressive cancers when they're young. So all these things we can talk about at another time. I think the bottom line is that one size doesn't fit all. Our bodies are different, our biology is different, our risk for breast cancer is different, and so screening probably should be too. And the way we're trying to do that is through the Wisdom Study. And, the reason we need to change is because despite our best screening efforts, 40,000 women are still dying of breast cancer. And as I had said earlier, the people who have these bigger cancers actually show up either between screens or before you're even at screening age. So we have to do a better job of trying to figure out who's at risk for these more aggressive cancers. And we actually do a lot of biopsies in women who don't have cancer. And, so that, and as we talked earlier, that is also really scary. And, half the cancers today still are found by women themselves. And one of the important messages we want to get across, if you find a mass that's new and different, your body better than anyone else, make sure you bring it to your physician's attention. Don't say, oh, well, I just had a mammogram 6 months ago, so it couldn't possibly be, because that's not true. And we want that message to be out there. That's a really important message, that people shouldn't ignore a new mass if they find it, regardless of what was found on their mammogram, in the last 6 months to a year. So again, we are trying to take all the lessons about breast cancer and apply it to screening. And, there's a whole laundry list of things that people get and that determine their risk: family history, genetics, how dense the breast tissue is. The breast tissue is made up of fat and glands and collagen, and that composition determines what the breast density is. And it turns out that affects your risk. Your race and ethnicity can sometimes predict what kind of cancer you're going to get. And, how old you were when you had your periods and when you had kids, and if you have kids, and whether you breastfed them and whether you took hormone replacement therapy, all those things make a difference. But we've had all these big advances in breast cancer prevention, which we don't apply very often or very well. There are advances in risk assessment through the way we screen and understand what your genes, how much risk you get from your genes. I'll talk about that for a minute. Actually, it turns out that you are protected if you have genetic information. A lot of people are worried about that, but there's two laws: the GINA Act and the Affordable, the HIPAA and the Affordable Care Act actually say you can't be discriminated against for a pre-existing condition. And it also shows that the Supreme Court said that you can't patent the genome. So that meant that companies like Myriad didn't have a monopoly on the sequences for testing the genes that, if you would inherit an error in one of them, it really puts you at a big risk for breast cancer. So then all of a sudden, all of these companies could use the advances in technology to come up with much more inexpensive and accessible tests to find out whether you inherit that risk. So sometimes you come from a small family, or maybe you don't know your family. Do you have a pre-existing genetic risk? Well, you can't know that unless, sometimes just from family history alone, and it's more accurate to actually just do the tests. And now it's, easy enough and affordable enough to be able to just do it on everybody. And that's one of the things that we're testing. We're trying to bring screening and prevention to the 21st century. And the acronym WISDOM is Women Informed to Screen Depending on Measures of Risk. And that whole idea is that we're trying to do this at large scale. We're trying to get 100,000 women to join. We want to test a new and personal approach that we hope will make a difference, that women will like better, that will be just as safe and actually more conducive to prevention. And so we're testing it. Whenever there's controversy, that's the time for a clinical trial, a clinical study. And we're going to talk about that in a minute. But that means testing a personalized approach versus every year screening. So we're trying to get lots of people to participate from all backgrounds so that our results apply to everybody. And we're very committed to making sure that this is accessible to women of every race, every ethnicity, and all backgrounds. So again, we're asking, is this personalized approach just as good? And that means more for some who have more risk and less for others that don't. Everyone will get some recommendation in this first version of WISDOM that's within one of the guidelines that's out there. So it's clearly an acceptable way to screen. Can we reduce the chance of biopsies and false positives? We think so, but that's why we're doing the study. And we hope that if we find people at higher risk, we can encourage them to be more interested in doing the things they can do or that we do know already to reduce their risk, and also start generating ideas for how to reduce risk in the future. And, we'll find out whether women prefer this approach or not. And the idea is, do we do better overall at lower cost to the individuals and society? So if you're assigned to the annual screening group, you just come in and get a mammogram every year. And if you are assigned to the personalized arm, we need 3 pieces of information: your mammogram, so we can look at your breast density. You have to answer a questionnaire that gives us information about your family history, your overall health, any previous biopsy you've had, and other questions. And then we actually do testing on the genes that you've inherited. It's a test you just have to spit into a little tube. And from that, we find that there are 9 genes that we look at, that if you inherit a mutation, an error in one of these where the proteins aren't made properly, it can really increase the risk of breast cancer. Now, this is not very common, but these are the people who have the most risk. And so we want to find those people and make sure that we can prevent them. And sometimes they're at risk for both breast and ovarian cancer. So we want to make sure that we can do what we can to prevent them. But then there's also a bunch of other little genes that you inherit. These are single genes, these or SNPs, that together we put together poly, meaning many, genetic risk, polygenic risk. And that we create a score, and I'll show you that in a minute. And that also contributes to whether or not you have risk. And we use a standard risk model from the Breast Cancer Surveillance Consortium that's been validated on 1 million women. And we've added this genetic information to make it better. And we can put people into 4 groups. If you're under the age of 50 and you don't have the average risk of a 50-year-old, you don't have to come in and screen till you're 50. If your risk is on the low, on the average or low side, you can come in every other year. If it's moderate, you come in once a year. And if it's quite high, you'd come in and alternate getting a mammogram and an MRI. And we actively do outreach to try and get you to learn more about what you can do to reduce your risk. And we just ask everyone to keep in touch with us, follow up. If anything happens, you get a call back. You can go to our site and upload it more. We send a questionnaire every year to find out what's going on. So I just wanted to turn to Nola for a minute, because we're often asked, why don't we just screen with MRIs? It's, there's none of that compression. It's just a lot easier. Why don't we use that for screening? So Nola.
So I want to, before mentioning that, I was going to make a comment a little earlier. I wanted to reinforce something that Margarita said about working in the healthcare profession and very much seeing how we're delivering MR and what the reaction of women and patients are about this exam. And it's less about, we'll get there on time and fill out paperwork, and more about what is this, what's it going to do? Is it helpful in these basic questions? And she's often answering those questions. I am African-American and Asian, and my background and my culture is very much in the Black community. And that her stories resonate completely with me as well, because on the one hand, I'm a scientist and I'm developing this high-end, equipment as part of my PhD thesis, but no one has a clue. In most, my friends, my family, my community, everyone I know has no idea. And despite even decades later, just talk about MRI and what is it? And MRI has really just been introduced to breast cancer management fairly recently, if you compare it to mammography and ultrasound. And there are lots of questions about it. What I notice, having been working in this field for many years, is that we have this really incredible new tool. That it sees almost all cancers in the breast. So it's highly effective. The problem is not everything it sees is cancer. So it means a lot of women get worked up on things that ultimately are falsely positive. And, both from a human factor and a healthcare factor, we can't sustain that high level of false positives. So a lot of what's happening in the field is to try to handle those a priori so that we're not generating false positives. So there is a lot happening there, and a lot that may move MRI into a realm where it can be less expensive, more available, more standardized and easily done. And that I think is that's a partnership with the healthcare providers, with scientists, with patients, with the community to say, if this is better and it can find more cancers more specifically, we need to make the equipment less expensive and more available. And all of that's achievable because we do that across technologies everywhere when there's a demand. And instead, we find ourselves in a little catch-22 because we're waiting for it to show that it can be done less expensively and more effectively, but we don't have the tools to do it. And so, if I have to put out my plug on what I think, my sense of there's no reason why we can't take these better tools and deliver them. So, but I have been doing this for several decades because I started when MRI was being just becoming a tool to use. So the other comment I would make about it is that machine is a full bells and whistles machine. It was designed to scan the brain. It scans the body, it scans the spine, it's all the extremities, arms and legs. So it's a one size fits all, very massive, very expensive, and not very well distributed system. So now we're saying, take that big, heavy duty machine, and sure, let's also do breast cancer, which means that to do a breast screening, you're still paying the exorbitant cost of a full bells and whistles MRI. So that's one thing that has to be addressed. If we do that, while it doesn't compress the breast, so you get some relief from not having breast compression, which is painful. We can't argue that it's completely, it's not a simple exam because you do have to enter the tube, as you see on the left. That big machine houses a big magnet, and the bore of the cylinder needs to be as small as possible. It needs to fit the majority of the population, but at the same time, as keeping it small makes the pictures better. But as your patient's body goes down into that tube, it's can make someone feel claustrophobic. It's anxiety provoking in and of itself. It's not most comfortable. You're squeezed into this small tube. And you do have an injection. Right now, you have an injection of a contrast agent. And hopefully we'll get away from that over the next few years. But I think that's big picture. There's a really, really, I guess going back, and I'll be quick, Laura's question was, why don't we use MRI more for screening? Right now, the impediment is that it's too expensive. It's not widely enough available. And most people don't understand it well enough to know, why opt this over that. And I think, those are the directions we need to go in.
Yeah, and I think so. Thanks, Nola. And I think that, doing these biopsies is also not trivial because sometimes you can't see them by ultrasound, and trying to then schedule an MRI biopsy is also really complicated. So, we are working really hard to find ways to make the screening exam, without contrast, and, ways to do this. We're hopeful for high risk screening we'll come up with something better. I'm fully confident that Nola can do that. But we would also say, if you are at high risk, the best test for you is an MRI. And we are convinced of that. A contrast, so that is actually really important for people to know. So most people don't need it, but when you do, if you really do have high risk, it's not an ultrasound, it's an MRI that's best for high risk screening. Let me just focus a little bit on the gene mutations and these, what we call this polygenic risk, and these variations. So there's still unexplained family history. So we always still ask about family history because we can't explain it all, but increasingly we're getting better and better. there are single gene mutations that maybe account for 1/4 of the people who have family risk. And fully 1/3 or more, actually, now we can explain because of these combinations of these small variations in genes that together is that so-called polygenic risk. And what does this mean? So these are, if you have one of these familial risk syndromes like BRCA1 or BRCA2, you have an 8 to 10-fold increase in your chance of getting breast cancer. This kind of intermediate genes like the CHEK2s, and that's another gene you can inherit that's in the middle. But then these common variants, these so-called SNPs, by themselves do not confer very much risk. But what you find is there's a group of people that have this high polygenic risk and a group of people that's lower. For the most part, this information helps us lower the estimated risk. But for this group of people here, it does bump some of these people up, and that's important. And we believe that's a really important advance. And there's more and more data coming out all the time. And why this is also important, when we started the study, so one thing about Wisdom is we're committed to making sure we update the model so that the results of the trial are not obsolete by the time the study is done. So at the beginning, there were only 75 of these SNPs. That was back in 2016 when we were designing the study. And we tried to, and we applied them all in some version for different women of different backgrounds to help incorporate their score. Today, we actually use different SNPs for women who are African American, Asian, Hispanic, or white. And that's what the data is showing us. And over time, there's a lot more data coming where in fact we can look at, anyone who's gone to ancestry.com may be surprised to find out what their ancestry shows them. But we can take that kind of information to help figure out which of these gene sets should be applied. So in the next year or two, this is going to get better and better still. And this is one of the reasons why it's so important that everybody participate, because we don't want to leave any particular group behind because we don't have enough information. And so we've made it a real cornerstone of the trial to make sure that we are opening and inviting this to all women. And for those women who have higher risk, we have a tool called a breast health decisions tool that helps women understand what their risk is, what all these different risk factors are. We have a breast health specialist who reaches out to do counseling, and we can refer people to those places that do can actually manage people to either take some of the medicines that lower risk. There's lots of new advances actually, and much lower doses of some of the standard medicines that we think have many lower side effects that we think people should consider. And so again, one of the reasons why we care a lot about making sure that we include everybody is that most of the studies have been done in women of European ancestry. So for many years, we only had information about the SNPs in white women, and that's really not good enough. So we think this is a unique aspect of what we're doing to individualize screening and prevention. And so we want to make sure that we can improve the accuracy of the tool, and that includes making sure that it applies specifically to women depending on their race and ethnicity. And so together, if we all participate, every woman spends 35 years screening. So you might as well spend the next 5 years with us. All you have to do is sign up, participate, follow the guidance that we give for 5 years, and fill out your surveys and keep in touch with us and help give us feedback, and we can make it better. So I want to just take a moment, maybe, Ricky, we were talking yesterday about what you think are some of the barriers that people hear when they hear about a trial. Is this going to be a sugar pill or something? And, the Wisdom study, this is just about, you're getting screening no matter what. And what do you think are some of the myths that would frighten people away from participating in a study?
The whole concept of the words clinical trial are scary. The word clinical sounds like a petri dish, and the word trial sounds like failure. So the whole premise is kind of scary and confusing to our community. If you could call it something different, that would be great. Um, and when you talked about, kind of a hesitancy to get a mammogram, when anyone tells me they're afraid of a mammogram or it's going to hurt, I said, cancer hurts more, trust me. So that's kind of my argument to say, get the mammogram, don't get the cancer. But it's all about education, and how we talk to people. And now a lot of the messaging that's currently being used by our sort of even our breast cancer ecosystem, Black women are just not hearing it. They're not hearing it. They're not getting it. We're not speaking their language. So a lot of the work that we're doing at Touch is to try to understand how to talk to people differently. I'm a marketing person. I'm not a scientist or a doctor. So I always think about what's the best way to message people. What imagery do we need to show them? What words do we need to use? And really, we have such a close-knit community. The message really is the most effective when it comes to from one of our peers. And there's such mistrust in the medical system. It's better to kind of work through influencers who can then take the message to other women and other people and other family members. And so it's how do you reach those influencers? And there's a lot of people, talking on social media and out in the world, but I think it's like, who is the right person to deliver the message? And then what words are you really using to convey the importance of this and how significant it is and how, it's a must, it's a thing you must do. It's not a choice. It's not a choice because you're going to die. And I always start, you talked a little bit about the mortality rate. The latest data that we've seen was from JAMA Oncology, really just a couple of weeks ago, that Black women with breast cancer have a 71% higher risk of death than white women. And that's atrocious. That's atrocious. So we've got to figure out how to do all of the science better to help to prevent Black women from dying. But the level of awareness and access to care and trust and really all of the social determinants of health are at bay here, and how to address them. But at the end of the day, it's who do you talk to? Who is talking and what are they saying to these women to say, you must do this, you must take care of yourself.
Well, it's interesting because, we know that the kinds of cancers that, that African-American women get are these triple negative cancers, and they are more aggressive, but there are better treatments for them. And one of the ways we figure that out is through trials like the I-SPY trial. And through those trials, we've also found, as I told you, hot off the press, that African-American women have the same chance of having a good response to some of these neurotreatments. So trials, in fact, are the opportunity to get access to tomorrow's treatments today. So I think there's a lot of education we need to do. Maybe we call it something else, but it's so incredibly important so that we make sure that people get the care that they need at the time that they need it.
So important. So important.
And if it turns out that it's not going to be most women aren't, most women don't get it. But if we could really find that 10% of women who really are at higher risk, not only could we screen them more frequently and find the cancers earlier, but we probably can start to develop prevention strategies specifically to reduce that risk. And that's really, that's cardiology's done that and reduce the risk of dying of heart disease. It used to be that you had a much bigger chance of dying of heart disease. But you know what? That doesn't happen because we have statins and we can manage your cholesterol. You can manage your blood pressure. People are getting more into diet and exercise. There are things that you can do, and they have lowered that risk such that your chance of dying of cancer is now just about the same, or maybe even a little higher of dying from heart disease. I say we have to get our mojo on and find ways to reduce that risk.
One of the things that we're doing, Dr. Laura, is we're reaching out to young women, and we have an HBCU internship program, and we have a bunch of young women who are pre-med, pre-science STEM students, and they are little brainiacs and awesome. And so not only are we educating them on breast health and how important it is to start checking your breast at a young age, but also I kind of view them as the conduit into the family. So they can say, hey, Mom, did you get your mammogram? Hey, Grandma, have you checked your breast? So they can kind of, what I say, bring health conversations to the kitchen table. Because right now they're not happening. And to me, breast health should be talked about like going to the dentist, getting your checkup, really anything. And so all those conversations need to be brought to the kitchen table where It's not uncomfortable. It's something that you talk about, and it's okay to, to put it out there and talk about it and make it something that's conversational in the families. And we're really kind of trying to engage these young women to train them to not only help themselves, but help their mamas and their grandmothers and the aunties and the whole family.
Yeah. And that's great, I think. So we'll just tell you a little bit about how to participate in the wisdom study, and then we'll take questions from the audience. So, you can enroll online on your phone, on a tablet, on a computer, in the library, public library, any place that has a computer that you can sign into. If you are in the personalized arm, actually you'll get a spit kit sent to your home, and we send you a picture of what it looks like. You get it, you open up, you follow the directions, and you put it back in its box, and you just mail it off. Everything is done online. There's only one piece of data that we have to have, and that's your mammogram report. And so we're just encouraging all women to get their mammogram reports and send them to us, because it's often easier for them to do it than for us to get it, but we work on both ways. And then from that, it takes us about 4 or 6 weeks to get all that information together, and we'll send you a screening recommendation. And we ask women to follow those recommendations for that 5-year period of time. And we will provide that information back to you. And there are 2 ways you can be in. One of the ways in trials that we really learned, which is better, is that we randomly assign people to personalized or annual. So you get a 50-50 chance of being in either one. And that's sometimes that is an important way for us to learn about which is better. However, we don't want anyone to say, oh, I don't want to do that. I want to do this or the other. If you feel strongly and you want to be in one arm or the other, then go to the place where the button where you can select it yourself, and you can either join the personalized screening or the annual screening. This helps us understand what women prefer. And we want to make sure that everybody knows that they're going to get a screening recommendation. No one is told not to screen, unless you're in your 40s and your risk is low, then you don't have to come in until you develop the risk of an average 50-year-old. So there's no placebo, there's no sugar pill. And, when you participate, you both give information and help yourself, your sisters, your mothers, your friends, but you also get things back. So we just want you to share with us a survey once a year. Share your mammogram reports. And if you're in the personalized arm, to just send that saliva sample back. And if you develop a cancer or your callback, you just need to let us know. So it's not a lot of work, but it's so important. And what you get back is a personalized screening recommendation. So when to start, how often to come, and when to stop, and whether or not you need that extra screening if you're in the high risk group. And we provide a letter of necessity to make sure that your insurance covers it. You can learn your genetic risk for breast cancer. And if you're at high risk, we actually have outreach with a breast health specialist. And if you have questions about it, you can request an appointment with somebody, and we can give you personalized risk reducing strategies. And again, you can, if you need an MRI, we will work with you to make sure that your insurance covers it. And we also we can give back pearls of wisdom. We can give you back information that comes out. So from Margarita's comments back, and Nola's and Ricky's, we're going to put together a little summary on what you should know when you go to get a mammogram and how you can advocate for yourself so it's not so hard. And there's no cost to participate. And it's women 40 to 74. Now you'd ask, like, how is this addressing, Ricky? You'd ask, like, why? What about the women who are under 40? Well, we have to start with where screening is done in this country now, from 40 to 74. But if it turns out that this is just as safe and more effective, then what we can say is that test that we do should basically be done. You can do that at any age. It doesn't test. That's just you as a baseline. We could implement that for all women at 30. And then you'd catch that small group of people that needed to be screened differently. But before we implement that nationwide, we have to, that's why it's so urgent that we get this done so we can work on the business of making it better for everybody. So if you've had breast cancer, you're not eligible. But if you haven't, you can join. Or if you've had breast cancer, but lots of people who haven't, tell them about the study. Wisdomstudy.org is easy. So you can live anywhere in the United States. And we want to make sure that the guidelines that come out of this study are applicable or relevant for everybody. So that's why we want every race, every ethnicity, all women to participate. So if you have learned enough and you like this, or you want to be an ambassador for the study, as Ricky said, the best way to do that is to go out into your community, and you are, as a trusted person, go out and tell people that really is the best way for us to spread this information. We're 35,000 strong. We just want to, in the next year, we want to double that number, and then we'll be able to get lots of great information and set the stage for a whole new paradigm. You know, as I like to say to women, demand the iPhone 20 of screening for yourselves and your friends and your family.
Love that.
So
So,
anyway, yes.
I was just going to mention, I know, Ricky, that you have to leave to go on another webinar. So thank you so much for joining. We still have time for questions, so everyone stay on, but just wanted to say thank you to Ricky for participating, being part of this important discussion.
Thank you,
We know
Jen.
we'll be working with you lots more now moving forward. So,
And Ricky, any final comments from you?
No, we are so excited to spread the buzz on this and get more people enrolled. You know, my oldest grandbaby is 3.5, and I have 10 years before she has boobs to get rid of breast cancer. So we have
Okay, let's do it. Let's do it. If we get this, if we double our enrollment, we'll have results in like 3 years, and we can do it. We can make a huge sea change. It would be amazing.
Let's do it. You know, my hashtag GSD. So thank you so much for having me, you guys.
Okay.
so if you have other questions, please enter them in the chat. We have some that we've been answering along the way. I think some questions have been around MRI specifically, and should that be an option instead of a mammogram? So Nola, if you want to maybe answer that for everyone, that would be helpful.
Sure. So it should not, MRIs do not and should not replace your mammogram. And one really important reason for that is a lot of cancers are picked up on a mammogram because they have calcium in them. Really important signal. And MRI cannot see calcium. So while MRI might pick up other things, it will miss some of those really important cancers. So at the moment, one does not replace the other. And really the recommendation now is for someone who's at an elevated risk, they will be recommended for screening MR, and the level of that risk is still being established.
And what is a good way to learn your risk?
The same mechanisms we've been talking about today. So a study like Wisdom is going to really help us hone in. You know, there are several studies that suggest that something in the, anywhere from 5 to 20% level, trials have been performed to look at the effectiveness of MRI in those risk categories. But those numbers were a little bit indiscriminately chosen. They just seemed about right. I think Wisdom will help us decide where is the right risk level, and looking at the SNPs and understanding really what a comprehensive risk score looks like. And because there is MRI happening in the trial, we'll start to learn exactly what level does it become very effective.
Mm-hmm.
And I think that, the people say, well, if I have dense breast, should I get an MRI? And I think that depends. People with very dense breast tissue have higher risk, but they may not have risk that's so high. But if you do meet that level of risk, definitely an MRI is the right way to go. And one of the good things about Wisdom is that there will be other opportunities to, extend some of the work that we're, to participate in some of the studies looking at kind of faster, more accessible, less expensive ways of doing MRI, right, Nola? So that, like, if we might take the next group of people who are not at the super high risk, but that other also high, that same group that we're reaching out to, and maybe offer participation in a study where we are adding the MR to really find out, are the false positives low enough, or is the value high enough to find other new cancers. Is that good enough? And we don't just want to tell people to start doing it because, if we screen someone said, why don't we just screen all women with dense breast tissues with MRI? Unfortunately, if we did that, that would actually cost about half the US defense budget annually. And so that probably is not the best way for us to use our resources. So what we need to do is find ways to, get dedicated instruments that are cheaper, faster, much better able to, much more suited to screening where the chance of finding a cancer is low. Would you say that's fair, Nola?
Yeah, that's actually where the community is driving for that. We have to have that.
Yeah.
One
Cheaper,
more
faster.
question. One more question is, what if the personalized recommendation is every 2 years, but one is not comfortable with that longer interval?
We'd encourage you to talk to us about that and sort of recall, again, if you are uncomfortable with the idea of screening every other year, then you should choose which arm you want to participate in and choose the annual arm. And I think that's probably the better way to go. If you want to have a conversation about it, there's like lots of physicians around the country who are involved in this and can have a conversation about it. And we tried to explain that, it's interesting that most countries around the world screen every other year, starting at 50. I think Sweden's the only one that starts at 45, but they screen like every 18 months in the 40s, late 40s, and then every other year. So, and actually in the UK, they screen every 3 years. So that it's, and again, most of the internists in this country are recommending that you screen every other year. So I think you can say that it's there. If the evidence was really clear that every year was better, there wouldn't be any controversy, but it's really not clear. And if you're in the personalized arm, you can feel confident that you're not in the higher risk groups where more frequent screening would make sense. I mean, there really is a lot of data out there. And so I think that's one of the questions that you have to ask yourself. Are you willing to follow the recommendations? And obviously that's an important part of the study, is to be able to follow those recommendations. So we would, if you want to talk about it, reach out to one of us and we're happy to walk you through it. It may be that you are better off just picking the annual arm, but it might be, as you understand it better, you'd feel, oh, well, this is actually tailored to me, so I feel more comfortable about it. This is something that is recommended pretty routinely by many internists anyway. And I feel like I'm not in that highest risk group. So I get some of the benefits of not having to go in all the time. As Margarita was saying earlier, not everybody loves going in and getting their mammograms, and you can feel safer about not having to go in as frequently.
Yeah. And then there was another question about X-ray risks and getting too many mammograms due to if you've had X-ray risk. Can you speak to the amount of radiation in mammograms? Is that still a concern?
Well, the amount of radiation, Nola, you probably know this better than me, has really, they've actually cut it down by 80%, and you can get the same, the same amount of information. And I think it's said that getting a mammogram exposes you to less radiation than taking a flight from San Francisco to Denver. Where we're more concerned about radiation risk is for women who are younger, up to the age of 35. But it's not as much of a risk in women over 35, especially with that small amount of radiation that's given today. Nola, is that different with 3D or not?
No, and I don't know the number off of the top of my head for the difference, but the 3D mammography is not substantially higher. There's a lot of attention to the radiation exposure, and what you were saying about younger women, it's cumulative. So the younger you start and more mammograms you have, there is some cumulative effect, but it's a very low dose. There's really not a lot of radiation risk associated with it.
Let's see, I don't see any other open questions. So just want to take the time. We are happy to answer questions after this session. So please do email your questions to us. Let us know if you would like to help to share the information about wisdom. We've got lots of ways to share on social media, by email, joining the study yourself if you're eligible. We will have the recording of this webinar available to everyone. It'll be on our website, and we can also send the link out to those who registered for the webinar today. So thank you so much to our panelists. Thank you to all of our attendees and all of our staff who joined today. We are so happy and appreciative of your time, and we are happy to answer any other questions after this webinar.
And thanks so much to Margarita and to Nola and to Ricky for participating with us today, and to Stephanie and Rashna and Allison for helping set it all up.
Thanks.
Thank you, everyone. Have a wonderful rest of your day, and we hope you will share your wisdom with us here at the Wisdom Study. Take care.
Thank you.